Hello, everyone, and welcome back to my YouTube channel. So, I'm Dr. Abhinn Miglani. So, in clinical practice, we often hear the terms clenching and grinding used interchangeably. So, or you can say clenching or bruxism interchangeably. But as clinicians, we know they are the worlds apart in terms of biomechanics and long-term prognosis. So, today we are breaking down the critical concepts to be understood regarding the vertical versus horizontal parafunction. So, whether you are a student preparing for a Viva or a practitioner looking to refine your diagnosis, this deep dive into the compressive versus shear forces will change how you look at occlusal wear. Let's get into the slides. Okay, just a second. Yes, so coming to the nature of movement and forces. So, a clencher has a vertical pathofunction. The activity is characterized by heavy static loading without any horizontal jaw movement. The forces involved are primarily compressive, acting along the long axis of the teeth, and in a bruxer, which is also known as an eccentric or an horizontal path of function, this involves the dynamic side to side or protrusive movements because the teeth are moving against each other under load. The primary stress produced is shear force, which is far more destructive to the dental structures and restorations. Okay, so in whenever we look at a parafunction, the first thing to evaluate is the direction of pathofunction or an abnormal function. In a clencher, the movement is purely vertical. So here in this first image, we can also see the long axis of the teeth. For all those who don't know about the long axis of the teeth, so this is a line which runs uh, along the parallel to the CEJ of the tooth, and it's basically perpendicular to the tooth. So uh, in a clencher, the movement is purely vertical. So imagine the jaw as a heavy press. It moves straight up and down with no side to side shifting. However, a bruxer moves in eccentric or horizontal patterns. This means the teeth aren't just touching, they're sliding across one another under immense pressure, which is far more destructive to the tooth structure over time. So, in this image we can see the tensile forces in which there are vectors of forces basically which move apart from each other. In compressive forces, the two vectors move towards each other, and the shear forces which turn to rotate or make the two vectors run opposite to each other out of a single object. So in this we come to the second slide, that is the patterns of the tooth wear. Okay, so how does this look inside the mouth? Because a clencher only moves vertically, the damage is usually localized. You will primarily see the functional cusp tips, the points of the back teeth starting to flatten out. So these are very layman terms. I will be reading out the slides afterwards. So in contrast, a bruxer experiences overall horizontal loss. This often results in what we call a flat plane of occlusion, where the entire chewing surface of the arch looks like it has been sanded down. So in a clencher, wear is usually localized. It is mainly the functional cusp tips that are lost due to the vertical nature of the habit. On the right side of this slide, you can see I have made a mnemonic. So basically, this image I have taken from the Google. I have not made it myself. So we can consider these for the functional cusps. So the facial cusps in the lower, that is the mandibular teeth, mandibular first molars, and the palatal cusps in the upper or maxillary molars, first molars. And in the bruxer, there is an overall horizontal loss of tooth material. As I said earlier, that it feels as if someone has grinded or attrited all the teeth intentionally with the sandpaper. So this results in a flattened occlusal plane and potholing or generalized attrition across the arch. So next, coming to the so we are coming to the soft tissue markers. So in a clencher, so because the cheeks are and tongue are often sucked or pressed against the teeth during a clenching episode, clinicians will typically see linea alba, a white line on the inner cheek, as you can see in the first image, and a serrated or a scalloped tongue. In the second image, in a Bruxer, there is basically no specific soft tissue findings as the dynamic movement does not involve the same type of prolonged static cheek or tongue pressing. So sometimes the teeth don't tell the whole story. So we look at the soft tissues. A clencher often creates a vacuum or constant pressure against the cheeks and tongue. This leads to linea alba, which is a white line on the inner cheek, and a serrated or scalloped tongue, where the tongue takes the shape of the tooth indentations. So interestingly, Bruxer often has no soft tissue findings. So coming to the clinical guidance, and also the we will be studying what is the prognosis of both in the second slide, in the after slide. So anterior guidance and condylar guidance are the two guidances we will be discussing here. So basically we look at how the jaw is guided. So the clenchers usually have steep condylar guidance and manage to maintain their anterior guidance. Don't worry if you don't know what are the anti guidances, I will be discussing it. And their front teeth still overlap and protect the back teeth. So this gives them a better prognosis because the biological safety mechanisms are still in place. So Bruxers, through years of horizontal grinding, often lose their anatomical guidance, often lose their anterior guidance entirely as the front teeth wear down. Okay, so combined with shallow condylar guidance, this creates guarded or difficult prognosis because the clinician has to rebuild the entire bite geometry from scratch. Okay, so for the ones who don't know what is an anterior guidance or a condylar guidance, so I will tell you. Wait. So in an anterior guidance, there is an influence of the contacting surfaces on the anterior teeth on the mandibular movements, while the posterior teeth are not in occlusion. In the condylar guidance, it is the path the condyles travel within the glenoid fossa during the mandibular movements. So the anterior guidance is the anterior determinant of the occlusion, which can be modified through the restorations, while the condylar guidance is the posterior determinant of the occlusion and can't be changed. So, anterior guidance protects the posterior teeth, ensures proper aesthetics, and the condylar guidance for articular settings and to understand the dynamics of the occlusion of the mandible. So, the anterior guidance should harmonize with the condylar guidance for smooth movements, while the condylar guidance sets the foundation that the anterior guidance should implement. Okay, so I will read the slide once for you. So in the anterior guidance, clencher typically maintains their anterior guidance because the vertical force doesn't grind down the incisal edges of the front teeth as aggressively. The bruxers often lose anterior guidance as the canine and incisal edges are worn flat by the horizontal excursion. Condylar guidance, clenchers are often associated with the steep condylar guidance. Bruxers exhibit shallow condylar guidance, which may be contributing factor or a result of the long-term horizontal wear pattern. Then coming to the prognosis, so the clenchers have obviously the better prognosis since the forces are compressive and anterior guidance is usually intact. It is often easier to manage with standard occlusal splints. And the Bruxer, due to the high shear forces, loss of guidance, and progressive horizontal destruction of tooth material, the long-term restorative outlook is more complex and requires more rigorous intervention. So if you want to see diagrammatically what we have discussed, so basically clenching is also a type of bruxism. Okay, so in the first image you can see the you focus at my face, the patient is moving the upper and lower jaw, compressing it towards each other. Grinding, there is side to side movement. Tapping, so I have this ASMR mic, so you might be able to hear what my tapping looks like. So what happens in bruxism? So on the left side, you can see there these are the common sequelae of the bruxism. Affraction, comes the recession and adhesion as compared to the healthy teeth on the contrary side. So coming to the treatment of both, so I have not made any slide for it, but I will discuss it with you. So basically, So clenching is often a semi-voluntary diurnal or the daytime habit, making it more responsive to the awareness and behavioral changes. So behavioral modification we can do is the techniques include habit reversal, where patients are taught to maintain a lips together, teeth apart position. So biofeedback, electronic monitoring can help patients become aware of the muscle tension in the jaw, allowing them to consciously relax. Stress management, soft splints, and always remember no hard splints need to be given in the clenching habit. And in the treatment of bruxing, we can give hard occlusal splints, that is the night guards. These are the gold standards for bruxism. A slim, hard acrylic guard is used to protect the teeth from abrasive wear and guide the jaw into a neutral position. It acts as a sacrificial layer that splint wears down, so your teeth don't. Okay. So the dental corrections we can do if grinding has already flattened the teeth or caused sensitivity, restorative work such as crowns or selective grinding can be used. Then sleep disorder management, since sleep bruxism is often linked to microarousals or obstructive sleep apnea, treating the underlying sleep condition. For example, we use CPAP machines and pharmacotherapy like muscle relaxants, like the clonazepam can be used. Depending on the patient to patient. Thank you for understanding, listening.